Hello everyone, so today we'll be looking at cardiac tamponade. At first I was trying to find out how pericardiocentesis is performed, and why not just read a bit about how to manage someone who comes in with cardiac tamponade. So I've come across patient.info. Let's see what they say about cardiac tamponade. So cardiac tamponade is caused by the accumulation of blood, fluids, pus, clots, or gas in the pericardial space, resulting in reduced ventricular filling and subsequent hemodynamic compromise. Cardiac tamponade is a medical emergency. Epidemiology, cardiac tamponade is rare. The incidence is 2 cases per 10,000 population in the USA. Cardiac tamponade related to trauma or HIV is more common in young adults. Cardiac tamponade due to malignancy and or chronic kidney injury occurs more frequently in elderly individuals. Causes often associated with pericarditis. Malignancy, especially breast cancer or lung cancer, acute myocardial infarction, and post-infarction, including Dressler's syndrome. Infective viral, including HIV, bacterial, for example, tuberculosis, fungal infection, connective tissue diseases, for example, systemic lupus erythematosus, also rheumatoid arthritis, dermatomyositis, systemic sclerosis. Radiation therapy, mixed edema, chronic kidney disease, post-operative cardiovascular surgery, hemorrhagic pericarditis, and idiopathic cause. Drugs can also cause it. What? Drugs cause cardiac tamponade. For example, hydralazine, isoniazid, minoxidil. I'm not sure how these drugs can cause cardiac tamponade. Can't really think of the mechanism. Diagnostic procedures with cardiac perforation. Okay. Trauma. Incidence of 2% in penetrating trauma, rare in blunt trauma, and surgery. Pneumopericardium, mechanical ventilation or gastropericardial fistula. And there's aortic dissection. Yeah, this can cause cardiac tamponade. Presentation, it may present subacutely with anxiety, fatigue, altered mental status, edema, or waxing or waning if intermittently decompressing. Dyspnea, tachycardia, tachypnea, cold and clammy extremities from hypoperfusion, because that's cardiogenic shock. So you have hypoperfusion. It is often accompanied by features of pericarditis. Symptoms vary with the underlying cause and how acutely the tamponade has developed. Symptoms vary with the underlying cause and how acutely the tamponade has developed. Okay, signs: distended neck veins, hypotension, tachycardia, tachypnea, and hepatomegaly. So signs of obstructive shock. Muffled heart sounds. Pericardial friction rub, present in 50% but may be transient. Acute tamponade leads to increased JVP. That's the Beck's triad of JVP distension, hypotension, and diminished heart sounds. This is rarely seen. Okay, what's Beck's triad? Jugular vein distension, reduced heart sounds, and what's the third one? Hypotension. Okay. There's pulsus paradoxus, which is exacerbation of the normal decrease in systemic blood pressure during inspiration. A pulsus paradoxus greater than 10 millimeters mercury helps distinguish patients with or without cardiac tamponade in patients with a pericardial effusion. This sign is more reliable in patients with high pressure rather than low pressure tamponade. Okay, so pulsus paradoxus. So during inspiration, your intrathoracic pressure decreases so that your lungs can expand. And when your intrathoracic pressure decreases, your heart expands. I guess, slightly, because of the negative pressure. And then, okay, if there is a pericardial effusion, or there's a cardiac tamponade. If there's a cardiac tamponade, the negative pressure will promote more fluids or air or whatever is causing the tamponade to go into the pericardial space. And hence the systolic blood pressure will fall more than usual. So more than 10 millimeters mercury. Then that is positive for pulsus paradoxus. Okay, JVP, the Y descent is abolished due to an increase in intrapericardial pressure, preventing diastolic. Oh. JVP, the Y descent is abolished due to an increase in intrapericardial pressure. The Y descent is abolished due to increase in intrapericardial pressure. So in the pericardium, intrapericardial pressure, Y descent, preventing diastolic filling of the ventricles. Cardiac tamponade causes an increase in both central venous pressure and pulmonary artery occlusion pressure. Okay, first I need to know what is the Y descent in the JVP. So I remember a YouTube video has good explanation. I think by 0 to finals. JVP. Yeah, this one.
The X descent starts with video. Hi, this is Tom from Ziphoid JVP. And this is quite a difficult topic, so my aim here is to really take it slow and explain simply so that you can really follow along each part of the JVP waveform and what you're seeing. So what is the JVP? Well, the JVP is a way to indirectly measure the pressure in the right atrium and in the venous system. So if the pressure in the right atrium is higher, then the JVP will be higher. Higher pressure in the right atrium, and therefore a raised JVP, can be caused by 4 things mainly: heart failure, fluid overload, constrictive pericarditis, and cardiac tamponade. How do we assess the JVP? Well, the jugular venous pressure, or the JVP, is assessed by looking at the right internal jugular vein. And this is a vein in the neck that can be visualized between the medial clavicle and the earlobe, and it runs underneath the sternocleidomastoid muscle. Bear in mind that the external jugular vein can be seen lateral to the internal jugular vein, and we don't use the external jugular for the JVP. We use the right JVP for assessment, as this sits most directly above the right atrium, so it gives us the best indication of what's happening in the right atrium. So to visualize the JVP, have the patient sit on their back at an angle of 45 degrees, and get them to turn their head slightly to the left. And it's quite useful to shine a light diagonally across the patient's neck so that you can see the change in shadows as you get that JVP pulsation. And what you'll see is a pulsation, a bit like a wave in the neck, with 2 pulses for each contraction of the heart. So if you feel a patient's pulse and watch their neck, for each beat that you feel with your fingers, you'll see 2 pulses in the JVP. And really it's more of a flutter underneath the sternocleidomastoid muscle rather than directly being able to visualize the vein. You can distinguish it from the carotid pulse in 2 ways. Firstly, because it has 2 pulses for each beat of the heart, but it will have twice the number of pulses as the carotid pulse. And you can also try to feel it with your fingers. And a carotid pulse will have a pulsation that you can palpate, whereas a JVP won't give you a palpable pulsation. So you won't be able to feel anything with your fingers. Another way to check whether what you're seeing is the JVP is to press on the liver or press in the right upper quadrant of the abdomen. And this will cause a temporary rise in a JVP. And this is called the hepatojugular reflex. To measure the height of the JVP, find the angle of the sternum, or the sternal angle, and measure vertically from this point, and then assess where the JVP is. And the vertical height from the sternal angle to the level of the JVP is the height of the JVP. So a normal JVP height is less than 3 centimeters. So a height above 3 centimeters would be considered a raised JVP. Next, let's talk about the JVP waveform. And there's 5 parts to the JVP waveform: the A wave, the first part of the X descent, the C wave, the second part of the X descent, the V wave, and then the Y descent. And after finishing this video, I think it's worth practicing just drawing and labeling this waveform for yourself and commit it to memory. And that should only take a couple of minutes, but it will really help to consolidate your understanding and make it easier when you start looking at the JVP to work out what's going on. So let's go through each wave and what is happening during them as far as the right atrium. And to do that, I want to use this simplified diagram that shows the internal jugular vein in the neck, which drains into the superior vena cava. And then underneath, you can see the inferior vena cava. Then there's the right atrium, tricuspid valve, the right ventricle, and the pulmonary valve that then leads into the pulmonary arteries that go into the lungs. The A wave happens during atrial contraction. So the right atrium is contracting against blood that's inside it. and this pushes the blood through the tricuspid valve and into the right ventricle. But the increased pressure in the right atrium not only forces the blood downwards, but also upwards, so the level of the blood in the internal jugular vein rises, and this rise is the A wave. The X descent is caused by relaxation of the atria, and the blood flows into the relaxed atria from the internal jugular vein, and this causes a drop in the JVP. At the start of the X descent, there's also blood flowing from the atria into the ventricle to complete the ventricular filling, and this also leads to a fall in the JVP. Next, we need to talk about the C wave. At the start of systolic contraction, the right ventricle contracts and squeezes blood out into the pulmonary artery, and this pressure pushes up against the closed tricuspid valve and causes it to bulge slightly into the atria. And this pressure into the atria from that bulging tricuspid valve extends into the superior vena cava, into the internal jugular vein, and creates this rise in the JVP that we call the C wave. The remainder of the X descent is caused by the final parts of the right ventricular contraction, where it's squeezed so small that it creates space in the pericardium, or the sac that fills the heart, for the right atrium to fill. So basically, the ventricle becomes very small and creates more space inside that sac so that the atrium has space to fill out. This acts a bit like a vacuum. The ventricle shrinks and creates space inside the pericardium for the atria to fill, so they expand and suck in blood, which causes the JVP to fall. The V wave comes next, and this happens when the atria relaxes and the right atrium starts to fill with blood. At this point, the tricuspid valve is still closed at the end of systolic contraction of the ventricles, and as the atrium fills completely, this filling starts to occur higher up into the superior vena cava, the internal jugular vein, and as a result, the JVP rises, and this is the V wave. And then finally, the Y descent occurs when the tricuspid valve opens and all the blood flows from the right atrium into the right ventricle. And this emptying of the right atria causes the
So Y descent is when tricuspid valves open. In the case of cardiac tamponade, when the tricuspid valve opens, blood should flow into the right ventricle, but because the pericardial space is pushing against the right ventricle, it would prevent the right ventricle from filling. Right? Is that why you lose your Y descent?
JVP to fall. At this point, the whole cycle restarts and the atria contracts and causes an A wave and so on. So let's go through it all again briefly as a summary. The A wave is caused by atrial contraction, causing the atrial pressure to rise.
Okay. Where were we? We were talking about the Y descent. JVP, the Y descent is abolished due to an increase in intrapericardial pressure, preventing diastolic filling of the ventricles. Yes, cardiac tamponade causes an increase in both central venous pressure and pulmonary artery occlusion pressure. Okay, cyanosis and pulmonary edema may occur. Your differential diagnoses include aortic dissection, cardiogenic shock, constrictive pericarditis, pulmonary embolism. Pulmonary embolism can also cause an obstructive picture, so it's one of your differentials. Right ventricular infarction and other causes of right ventricular failure. Acute severe asthma, tension pneumothorax, large pleural effusion. Tension pneumopericardium, usually seen in infants with mechanical ventilation, but also may follow sternal bone marrow aspiration, penetrating chest wall injury, esophageal rupture, and bronchopericardial fistula. Okay. Investigations include creatinine kinase and isoenzymes, elevated in myocardial infarction and cardiac trauma. Renal function, you want to diagnose uremia. Why uremia though? Suddenly uremia came up. Maybe uremia can cause a pericardial effusion as well somehow. Never mind, FBC for infection, anti-nuclear antibody assay, ESR rheumatoid factor, assessment of possible connective tissue disease etiology, HIV testing. Approximately 24% of all pericardial effusions are associated with an HIV infection. Okay, that's quite a high percentage. Testing for tuberculosis, an important and not uncommon cause. ECG features may include sinus tachycardia, low voltage QRS complexes, alternation of QRS complexes, usually 2:1 ratio, PR segment depression, PR segment depression. Okay, chest x-ray, cardiomegaly, water bottle shaped heart, or globular shaped heart, pericardial calcifications, or evidence of chest wall trauma. Echocardiography, transthoracic echocardiogram is the investigation of choice. Echocardiography, transthoracic echocardiogram is the investigation of choice. Okay, it's fast. You can do it in the bedside, and you can confirm straight away. MRI or CT scanning, the advantages being improved field of view and ability to detect calcifications. Swan-Ganz cardiac catheterization. Pericardiocentesis, Aspirate sent for culture and cytology. Aspirate pericardiocentesis, yes, sent for culture and cytology. Okay, pericardial biopsy may occasionally be required. Management, okay, this is what we want to know. Patients should be monitored in an intensive care unit. Pericardiocentesis, echocardiography guided being the procedure of choice, is the definitive treatment, but may be hazardous and not relieve symptoms in case of small effusions associated with constrictive pericarditis, for example, malignancy, autoimmune conditions, and viral infection. You want to give them oxygen, volume expansion to maintain adequate intravascular volume. Small boluses work the best. Improve venous return, bed rest with leg elevation. Positive inotropic drugs, for example, Dobutamine, make their heart pump harder to compensate for it not being too filled properly. Positive pressure mechanical ventilation should be avoided because it may decrease venous return. Positive pressure mechanical ventilation. Okay, yeah, because so you're increasing the intrathoracic pressure when you're giving positive pressure. So you might compress on the inferior vena cava and superior vena cava, which is giving the heart their venous return. Further medical care includes echocardiogram guided pericardiocentesis. Further medical care includes echocardiogram guided pericardiocentesis. Removal of pericardial fluid is the definitive therapy for tamponade. Emergency subxiphoid percutaneous drainage is the safest method for emergency pericardiocentesis. It is most safely performed under guidance by echocardiography. Echocardiography reduces the risk of complications such as perforation of the right atrium. There's percutaneous balloon pericardiotomy. Treatment of the underlying cause. Okay, let's look at each of these. It'd be easy if we have a picture of it. Yes. So this is how you do it. Is there any specific anatomical landmark that we need? Is there a YouTube video on it? Okay, and there's one video by Open Pediatrics. They are quite nice videos. This one is a mannequin. Okay, this one looks real. This one is of an animal. Okay, let's look at Open Pediatrics.
In cardiopulmonary resuscitation. Pericardiocentesis during cardiopulmonary resuscitation by Dr. Tracy Wolbrink. Introduction. Pericardiocentesis is performed in patients with cardiac tamponade in order to restore cardiac output. In this video, we will be demonstrating the blind technique that is used when a patient has an emergent need for pericardiocentesis, such as when a patient is receiving active cardiopulmonary resuscitation. It should be noted, however, that whenever possible, this procedure should be performed by a specially trained healthcare professional under ultrasound or fluoroscopic guidance. Indications and contraindications. Patients with cardiac tamponade have accumulation of either fluid, blood, and/or air in the pericardial sac, causing increased pressure, limiting the ability of the heart to fill, thus decreasing cardiac output. Signs of cardiac tamponade may include tachycardia, narrow pulse pressure, hypotension, pulsus paradoxus, jugular venous distension, decreased heart sounds, enlarged cardiac silhouette on chest X-ray, pericardial effusion on echocardiogram, and low voltage QRS or electrical alternans on EKG. Patients may present clinically with dyspnea, tachypnea, tachycardia, poor perfusion, and/or change in mental status, including agitation, and thus a high degree of clinical suspicion is required to make the diagnosis. Patients at risk for pericardial tamponade include those that have had recent cardiac surgery, trauma or injury, cancer, renal disease, infection, or autoimmune or inflammatory disorders. Cardiac tamponade is one of the H's and T's that healthcare providers should remember when providing cardiopulmonary resuscitation on a patient who has pulseless electrical activity. There are no absolute contraindications to emergency pericardiocentesis. The following equipment is needed for emergent pericardiocentesis. Appropriate personal protective equipment, including sterile gloves, emergency resuscitation medications and equipment, cardiac monitoring devices, an aseptic skin cleanser such as chlorhexidine, a large needle or spinal needle with a trocar removed. A 20 or 21 gauge needle would be acceptable for a child, and an 18 or 19 gauge needle would be acceptable for an adult. Syringes. It is helpful to have both a small 5 to 10 milliliter syringe and a large 20, 30, or 60 milliliter syringe. Slip tip syringes are preferred, but Luer lock syringes would also be acceptable. A 3-way stopcock with T-connector. If the infusion is of large volume, then the T-connector can be attached to the spinal needle and the 3-way stopcock to the T-connector. When the syringe is full, the stopcock can be turned off to the patient to allow emptying of the syringe into a container without having to disconnect the syringe repeatedly. Alternatively, the syringe can be disconnected from the T-connector, emptied, and then reattached. Both of these techniques reduce the risk of accidentally dislodging the needle from the pericardial space while manipulating the syringe. And both are most easily accomplished with the second provider manipulating the syringe while the first provider stabilizes the needle. Positioning and landmarks. During active cardiopulmonary resuscitation, the patient will be in supine position. The xiphoid process should be palpated, and a subxiphoid approach, which is between the xiphoid process and the left inferior costal margin, will be the most optimal approach to use when a patient is actively receiving CPR. Procedure. Start by cleansing the skin. During active cardiopulmonary resuscitation, the patient will not require local anesthesia, but this should be considered for elective or semi-urgent procedures. Connect the syringe to the needle gently so that it may be easily removed without disrupting needle position. Cardiopulmonary resuscitation should be briefly paused during the advancement of needle and the aspiration of syringe. Insert the spinal needle in the subxiphoid region between the xiphoid process and the left inferior costal margin. Angle the needle underneath the ribcage no more than 45 degrees to the patient's skin, and aim the needle towards the patient's left shoulder as you continuously aspirate the syringe. Short, quick jabs, as opposed to slowly advancing the needle, are required in order to penetrate the parietal pericardium and to not tent it against the visceral pericardium. Advance and aspirate the needle until fluid, blood, and/or air is obtained. The distance from this asphalt gap the patient's left shoulder as you continuously aspirate the syringe. Short, quick jabs, as opposed to slowly advancing the needle, are required in order to penetrate the parietal pericardium and to not tent it against the visceral pericardium. Advance and aspirate the needle until fluid, blood against the visceral pericardium in order to penetrate the parietal pericardium as
Slow, quick jabs.
opposed to slowly advancing the needle are required in order to penetrate the parietal pericardium and to not tent it against the visceral pericardium. Advance and aspirate the needle until fluid, blood, and/or air is obtained. The distance from the skin to the pericardium is based on body habitus. If no fluid is obtained, withdraw the needle to just underneath the skin and angle the needle more posteriorly, closer to a 45-degree angle, and re-advance the needle while continuously aspirating. Remove and flush the needle after several failed passes. If ultrasound is available, confirm the needle is in the pericardial space and not in the heart with an apical 4-chamber view. Secure the needle at the skin with your other hand to make sure the needle does not move unnecessarily during the procedure. Change to a larger syringe and continue removing fluid. Remove the needle when you can no longer aspirate fluid, and remember to resume cardiopulmonary resuscitation. Complications. Complications include cardiac arrhythmias, pneumothorax, accidental puncture of the heart or coronary vessels, or injury to the stomach, liver, diaphragm, or other internal structures or organs. Post-procedure monitoring and documentation. Continue cardiopulmonary resuscitation and monitor for any change in hemodynamics. An echocardiogram should be obtained as soon as possible following the procedure if return of spontaneous circulation is achieved. Remember to document the amount and quality of pericardial fluid removed and to send fluid samples for analysis, including cell count, protein, and culture as indicated. This concludes the video on pericardiocentesis.
Cool. This video is quite complete. So we actually learn what's the anatomy. So you would do it between the xiphoid, the end of the xiphoid and the left left subcostal margin. And you would point it towards their shoulder at about a 45-degree angle. And then you do short pushes, short and quick jabs to try and puncture the pericardium. If you have an ultrasound to guide, then it'll be much better. Yeah, I guess we already reached our goal for this video. Let's read this again. Patients should be monitored in an intensive care unit. Pericardiocentesis is the definitive treatment. May be hazardous and not relieve symptoms in case of small effusions associated with constrictive pericarditis. You need to give them oxygen, volume expansion, small boluses, improve venous return by putting them on bed, and you can also try elevating their legs. Give them positive inotropic drugs such as Dobutamine. Positive pressure mechanical ventilation is avoided. Further medical care includes echocardiogram guided pericardiocentesis, as we saw just now. And then there's the emergency subxiphoid percutaneous drainage. This is the one without the ultrasound. It's the safest method for emergency pericardiocentesis. It is most safely performed under guidance by echocardiography. Echocardiography reduces the risk of complications such as perforation of the right atrium. And then percutaneous balloon pericardiotomy. What is this? Balloon pericardiotomy. What is this? Percutaneous balloon pericardiotomy. So we see a picture. But there's no description. So you put a balloon there to keep the needle there, is it? So that it continue draining. Percutaneous balloon is a procedure done to drain excess fluid in the sac around the heart. Yeah, so it's for drainage. Percutaneous balloon pericardiotomy, PBP, is a procedure done to drain excess fluid in the sac around the heart. The procedure uses a long thin tube with a balloon attached. Fluid is drained out through the tube. A fibrous sac called the pericardium surrounds the heart. The pericardium consists of two thin layers with a small amount of fluid between them. The fluid reduces friction. We know what a pericardium is. Okay, during PBP, a doctor inserts a needle through the chest wall into the tissue around the heart. Once the needle is inside the pericardium, the doctor removes it and replaces it with a long, thin tube called a catheter. Oh, this tube has an inflatable balloon at its tip. Repeated inflation of the balloon creates a small hole or window in the pericardium. When the hole is large enough, the doctor removes the catheter and balloon and replaces them with a new catheter for final draining. This allows fluids to drain out of the pericardium, which improves heart function. I see. So the balloon is meant to make the hole bigger, so you put another catheter in. I see. There are surgical management, pericardiodesis. What is pericardiodesis? Wait a minute. There might be differences between pediatrics and adults because their anatomy might be a little bit different. So let's look at, is this an adult? Let's see how they do it here. Or is this?
Ultrasound. That's not an excuse to punish your patients with radiation. Get out there, ultrasound's hearts, lungs, might be skewed. A pericardial effusion can be visualized best from the subcostal window, looking through the liver. The effusion will look like an anechoic stripe surrounding the heart in this location. Here's an example of a small pericardial effusion. In this particular effusion, there's no evidence of pericardial tamponade, which is, of course, the thing we are most concerned about, and the reason for performing a pericardiocentesis. Pericardial tamponade can be visualized on ultrasound, but it's not 100% sensitive, so if a patient has a good clinical presentation in the presence of an effusion, you really have to worry about tamponade until proven otherwise. When we think about pericardial tamponade with ultrasound, there's three things that we look for. The first and probably the most important is right ventricular collapse. This is an example of right ventricular collapse from a pericardial effusion causing tamponade. Here we see the free wall of the right ventricle is collapsing during diastole. The next thing we look for is the presence of a collapsed LV. So we think that if the patient has a reduction in forward flow because of collapsing of their right ventricle, the LV is therefore not filling. This makes the LV hyperdynamic, meaning that the walls touch during systole. So this patient, for example, has an ejection fraction of approximately 100% because the LV walls are touching during systole. This is because the LV is not filling appropriately because of the lack of forward flow coming from the right side of the heart. The last thing we're looking for is a dilated IVC. If someone doesn't have appropriate forward flow because of lack of filling of the right side of the heart, we expect the blood to back up into the inferior vena cava. To look at this, we're looking at a subcostal window. This is a subcostal long axis window, and you see the effusion here. Here we see the liver, and the IVC is nice, fat, dilated, and not collapsing at all with respiratory variation, telling me that there is a significant reduction in forward flow. To perform a pericardiocentesis with ultrasound, you're going to need a couple of things. The first and most important is obviously the ultrasound machine, and we can use either the curvilinear abdominal probe if we're performing a subcostal technique, or we can use the thoracic probe or the cardiac probe if we're performing a apical technique or with the subcostal technique. Of course, you also want a pericardiocentesis tray. Now, you don't have to have, or we can use either the curvilinear abdominal. To perform a pericardiocentesis with ultrasound, you're going to need a couple of things. First and most important is obviously the ultrasound machine, and we can use either the curvilinear abdominal probe if we're performing a subcostal technique, or we can use
Subcostal.
the thoracic probe or the cardiac probe if we're performing a apical technique or with a subcostal technique. Of course, you'll also want a pericardiocentesis tray. Now, you don't
So there are two techniques. There's apical technique and subcostal technique.
have to have one of these. If you're not placing a catheter, you can simply use a spinal needle and a large syringe. However, if you do want to place a catheter, I recommend you keep a pericardiocentesis tray in your emergency department. There's two particular windows that we use when we perform a pericardiocentesis under ultrasound guidance. That's the subcostal window, which is the more classic window, performed usually without ultrasound guidance, and then the apical window, which has gained a good bit of popularity since the use of ultrasound for guiding this procedure. Some people also use a peristernal technique going in the third or fourth intercostal space. However, I prefer not to use this due to the location of the left anterior descending artery. The concept of lacerating that artery just sort of scares me. This is an example of performing an ultrasound-guided pericardiocentesis from the subcostal window. The steps that we mentioned here are pretty much the same steps that you would use for the apical window, the only difference being the orientation of the ultrasound probe. For this particular example, we're using a curvilinear abdominal probe. However, you could also use the thoracic or phased array probe for this particular image. Here we see we're looking at a heart with a fairly significant diastolic collapse of the right ventricle and a fairly large effusion. We're going to be coming through the liver here, and we're actually visualizing the pericardium through the liver here. I'm going to insert the needle just lateral to the probe to the patient's right side. That way I'll be going through the liver and towards the patient's pericardial sac. As I insert the needle and draw back, I'll get a flash of blood into the syringe. Once I've seen this blood, I'm going to confirm that it appears my needle tip is in my pericardium. After I do that, I'll take the syringe off, and I'll place a wire through the needle into the pericardial sac. Again, confirming that the wire is in the pericardial sac and not the ventricle. I'll use ultrasound for this confirmation. Then I'll slide a dilator over the wire, and finally pass a catheter over the wire and remove the wire. At this point, I can place the wire to downdrain to drain the pericardial effusion. Here's an example of a real-time performed pericardial effusion. Here we're using the phased array probe from subcostal window, and you can see the needle coming in just about right here. We see we've popped through the pericardium, and once we pop through the pericardium, we're going to start advancing our wire down. You can see the wire pushing down on the right ventricular free wall here as it goes into the pericardial sac. After the wire, we'll of course push the dilator over the wire. Here we see the dilator coming in, and then finally the catheter will be placed over the wire into the pericardial sac. Once the catheter is in place and it's hooked up to downdrain, you can actually see the pericardial effusion diminish in size. And here we can see that pericardial effusion getting much smaller.
Oh.
In addition to the subcostal window, you can also use the apical four-chamber window. For this particular window, I'll again place the needle just lateral to the probe. However, this time I'm going to come from a medial orientation directed towards the apex of the heart. I'll again be able to see virtually the same thing that we saw with the last image. However, we'll of course use the phased array probe in this instance because it's much easier to visualize through the rib spaces with a phased array probe rather than with a curvilinear. A few tips and tricks. So agitated saline is a great technique for making sure that you're actually in the pericardial sac as opposed to placing the needle or the wire into a ventricle. Here's an example of injecting agitated saline into the pericardium once you have the needle in what you believe is the pericardium. You can see how the agitated saline lights up and is extremely hyperechoic in the pericardial sac here. If we were inside a ventricle, say the left ventricle for example, we would see the left ventricle light up as opposed to remaining dark here. Agitated saline can be a great way to confirm that you're in the right location, especially if you're trying to tap a small pericardial effusion or if you're just not very comfortable with placing a large dilator into a ventricle. Needle in plane technique. Some people talk about using the needle out of plane technique, which would mean going with the needle through the center of the probe. However, I prefer having the needle come in laterally so that we have the needle in plane and in view the entire time. This allows us to see the needle tip and really know where it is in space. So I'll have the needle come in just lateral to the probe, and then that way I know where to expect it on my screen. I would expect the needle coming in just here laterally going towards the pericardial sac. Again, I'm going to have the needle actually come in right next to the probe marker. That way I know to expect the needle coming from the probe marker as seen here. Go where the fluid is. It's important to remember that with pericardiocentesis there is a margin for error as possible. So wherever the pericardial effusion is the thickest is probably where you should go with your needle. If that happens to be peristernal, even though Malin said don't do it on his little podcast, go for it. Whatever you think, whatever you're most comfortable with. So apical, subcostal, peristernal, wherever that effusion is the largest is probably going to give you the best chance of success without taking out a ventricle and placing a catheter in someone's aorta. Some good news and some bad news. Bad news is we had a couple.
Cool. This is a very good video actually. Okay. What is this? Pericardiodesis. So in adults and pediatrics, actually you use the same technique. There are two techniques. There's the subxiphoid and there's the apical technique. Yeah. Emergency, you will use the subxiphoid. Okay. Pericardiodesis for recurrent pericardial effusion or tamponade. Corticosteroids, tetracycline, antineoplastic drugs can be instilled via intrapericardial catheter into the pericardial space. What is pericardiodesis? This is pericardiocentesis. What is pericardiodesis? Pericardiodesis didn't even have pericardiodesis. Yeah, I'm spelling it correctly. Synthesis. Guess there's no search result on desis. Search instead pericardiodesis. Oh, here, okay. It's the same website we're looking at here. Is there any images on it? No. At least give me a explanation. The PDF. Pericardiodesis. What is this? Okay. So there is no explanation on the procedure. It's just an abstract. Can I actually access this? Let's try. No. Can't access it. Too bad. Knowledge should not be behind paywalls, you know? Never mind. Pericardial peritoneal shunt may help prevent recurrent tamponade. Pericardiectomy. Resection of the pericardium is rarely required. Prognosis, the risk of death depends on the speed of diagnosis, treatment provided, underlying cause of the tamponade. Early diagnosis and treatment are crucial to reduce morbidity and mortality. Okay, so in conclusion, whenever there is a pericardial, when you suspect pericardial tamponade clinically, you're gonna want to do an ultrasound really quickly to confirm it. And it's the best imaging modality. It's fast and it's accurate. You can see the whole heart, whether there's any effusion in the pericardial space, and you can see whether it's tamponading the dilatation of the heart. And based on ultrasound podcast just now, this guy said that even if the ultrasound is negative and clinically you see that this is obviously cardiac tamponade, then you would go ahead with pericardiocentesis anyway. And then pericardiocentesis, there are two methods. That's the subxiphoid approach and that's the apical approach. Best guided with ultrasound, but if in emergency settings without an ultrasound available, then you want to go for the subxiphoid approach. And then other things that you can do is to increase their cardiac contraction and give small fluid boluses and give them oxygen as well. Yep. I think that's overall management of somebody presenting with cardiac tamponade. Thanks for watching the video. I hope it helps. See you next time.